Look down at your left leg right now. Like, really look at it. You can see it. You can feel your foot resting on the floor.
Right, you just know it's there.
Exactly, without a shadow of doubt that it belongs to you. But I want you to imagine the absolute visceral panic of looking at that perfectly healthy leg, and your brain is just screaming at you that it's like an alien
Oh,
object.
wow, yeah.
It feels profoundly wrong. It shouldn't be there. And we're not talking about some fleeting, weird, intrusive thought.
No, it's much heavier than that.
Right. It is a deeply agonizing 24/7 conviction that this part of your body must be completely removed for you to actually feel whole.
It's, it really is a profoundly unsettling reality to try and step into. I mean, most of us just naturally assume that our physical bodies and our mental maps of ourselves are, perfectly aligned.
Yeah, we definitely take it for granted.
We really do. We take that feeling of being at home in our own skin completely for granted.
We operate under the assumption that the brain and the body are permanently happily married. But what happens when the brain fundamentally rejects the body?
That is the big question.
Right, and that's exactly what we are exploring in today's deep dive. We're looking at this fascinating and frankly pretty heavy article from Psychology Today by Dr. Sebastian Montel.
He's a licensed clinical psychologist, right?
Yeah, and he breaks down this condition known as body integrity dysphoria, or BID. And, our mission today isn't to just gawk at some rare medical anomaly.
Wow, definitely not.
We want to understand what this condition actually reveals about the profound and honestly incredibly fragile mechanisms that connect our brains to our bodies. So, okay, let's unpack this. What exactly is the clinical reality of body integrity dysphoria?
So at its core, the clinical definition of body integrity dysphoria is this intense, persistent, and just unyielding desire to modify your body by acquiring a physical disability.
And we are talking about major life-altering modifications, right?
Oh, absolutely. The most common is the amputation of a specific healthy limb, but it can also manifest as a desire for paralysis or even blindness.
Wait, blindness? Really?
Yeah, it's extreme. And the crucial diagnostic criterion here is that the patient desires this extreme modification despite there being absolutely no medical necessity for it.
So the limb or the spine or the eyes, they're all functioning perfectly.
Precisely. They work perfectly fine.
Dr. Montel grounds this heavily in the human experience, which I appreciate. He shares the case of a 24-year-old man named Alex.
Right, the Alex case study.
Yeah, Alex is physically healthy, but since he was a young teenager, he has been completely consumed by the urge to have his left leg amputated.
It's just so hard to imagine living with that.
It really is.
Yeah.
When you read the details of his daily life, you realize this isn't like a quirk or a passing fascination. We are talking about severe emotional distress.
It's a constant weight.
Exactly. It's a heavy, constant weight that impairs his ability to work, to socialize, to just, exist comfortably.
And that sheer, unrelenting exhaustion is exactly why the psychiatric language surrounding this condition has shifted so significantly. What's fascinating here is how the medical community's understanding of this experience has evolved over time.
How so?
Well, if you look at older psychiatric literature, you'll see this condition referred to as apotemnophilia.
Apotemnophilia. I mean, that sounds incredibly clinical, but the philia suffix usually carries a lot of baggage in psychology, right?
It does, yeah, and that was a massive problem. That older term carried a heavy stigma. It often implied that the desire for amputation was some kind of paraphilia.
Like a fetishistic or purely behavioral compulsion.
Exactly. It made it sound like a lifestyle choice or, a sexual quirk. But the shift to the modern term, body integrity dysphoria, is a really crucial pivot in how we understand the patient's reality.
Because of the word dysphoria.
Right. Dysphoria is derived from the Greek word dysphoros, which translates directly to hard to bear.
Hard to bear. Wow, that completely reframes the entire condition.
It really does. It centers the pain. It shifts the medical focus away from how strange the desire for amputation might seem to, like, an outsider.
Right. It stops treating it like a freak show.
Exactly. And it puts the focus squarely on the psychological agony the patient is trapped in. They are living with an internal reality that is fundamentally hard to bear.
But, hang on. If someone perfectly healthy rolls into work in a wheelchair, or is seen walking around their neighborhood on crutches when their legs work perfectly fine.
Yeah, the pretending behaviors.
Right, the source mentions those pretending behaviors. aren't people and even medical professionals just going to write that off as an extreme cry for attention?
Hmm.
It seems like it would be really easy to dismiss this as someone just wanting the sympathy that comes with a disability.
That is probably the most common misconception, honestly. And it's one that causes patients an immense amount of additional suffering and isolation.
I can imagine.
But the psychological literature makes it abundantly clear this is not about seeking attention. This is a fundamental identity mismatch.
So it's not a performance.
No, not at all. When someone with BD uses a wheelchair, they aren't doing it to get people to look at them or to garner sympathy. They're doing it to temporarily align their physical reality with their internal mental map.
Oh, wow. So sitting in the wheelchair actually brings them a sense of internal relief, not external validation.
Precisely. And the proof that this is a deeply rooted internal identity issue, rather than some external attention-seeking behavior, is found in the extreme emotional distress these patients feel when they cannot achieve their desired body modification.
Because if it were just about attention, they'd just do something else, right?
Exactly. Human beings are very adaptable. The patient could easily pivot to some other dramatic behavior to get noticed. But the distress in BD is laser-focused exclusively on the specific discrepancy between their physical body and their mental map.
That makes a lot of sense.
In fact, these pretending behaviors, like brining a leg or using crutches, they're often done in strict privacy. It's a mechanism for self-soothing, a profound internal incongruence.
That's fascinating. And if this is a fundamental flaw in how someone's physical identity is formed, it makes sense that we'd see this taking root very early on, right?
Oh, absolutely.
Because the text lays out some demographic data, and the timing seems really significant.
The timing is arguably one of the most critical pieces of the puzzle here. The data shows that the onset of BD typically begins very early, usually in childhood or right before adolescence.
Which tells us we aren't looking at like a coping mechanism developed by an adult who is just super stressed out by their life.
Right, it's not midlife burnout.
Yeah, this is something taking root precisely when the brain and the concept of self are still under major construction.
Exactly, the brain is actively mapping itself during those years. The data also notes that BD is extremely rare, though, precise numbers are really tough to pin down due to the massive stigma and underreporting.
Sure, people are probably terrified to talk about it.
Exactly. But from what we know, it mostly affects males. And furthermore, the desire is most frequently targeted at the lower limbs, just like Alex wanting his left leg amputated.
There's actually a specific detail from Dr. Montel's text regarding the demographics that really stood out to me. He notes that most reported cases of BID come from Western countries.
Yes, that's a heavily debated point.
Right. So does the research suggest this is a uniquely Western psychological phenomenon? Like, is there something about Western culture that breeds this specific type of body dysphoria? Or do Western cultures just provide a medical infrastructure where people feel slightly safer disclosing something so stigmatized?
That is the classic epidemiological mystery, right? Are we seeing more of it because it actually happens more in these regions, or simply because we have the systems in place to count it?
Right, exactly.
Well, the cultural discrepancy remains a bit of a mystery. The text gives us a really vital clue to analyze this. Dr. Montel explicitly notes that BID affects individuals regardless of their educational or socioeconomic background.
Oh, interesting. So it crosses all income and education levels.
It does. And that widespread socioeconomic presence is a massive indicator. When a condition appears consistently across wildly different levels of education, income, and social class, it hints strongly that we are dealing with a deeply rooted biological or psychological mechanism.
It's not a luxury of the rich, and it's not a byproduct of a lack of education.
Exactly. It is foundational. Now, culture absolutely dictates how a symptom is expressed, and certainly whether someone has the vocabulary or the safety to report it to a researcher.
Right. The cultural software, so to speak.
Yeah, exactly. But the sheer consistency of the core symptoms, specifically targeting a lower limb and starting in early childhood, it really points to a hardware issue,
Yeah.
not just cultural software.
That makes perfect sense. If it crosses all those lines and starts in childhood, there just has to be a physical mechanism at play in the brain.
There does, yes.
I was actually trying to wrap my head around the neurobiology mentioned in the article, and I kept trying to visualize it. Think of the brain's body map like a car's GPS.
Okay, I like where this is going.
So you're driving and you're looking out the windshield and you can clearly see a perfectly paved road. That's your healthy left leg.
Right.
But the internal GPS on the dashboard is absolutely screaming that the road shouldn't be there. It's just flashing red saying, turn back, this isn't a road. And it's causing absolute panic because the visual and the internal map violently reject each other.
If we connect this to the bigger picture, that GPS analogy is astonishingly accurate to what is actually happening neurologically.
Oh, really?
Yeah, your brain doesn't just passively receive information from your body. It actively constructs a continuous unified map of it. And Dr. Montel's article points to specific neuroimaging studies that show us exactly where that internal GPS breaks down in patients with BID.
Right. The text mentions atypical brain activities, specifically congenital dysfunction in the right parietal lobe and its connection with the insula.
Yes, and congenital means this vulnerability is present from birth. Let's break down why those two specific areas actually matter.
Yeah, please do, because it gets pretty dense.
So the right parietal lobe is heavily involved in spatial awareness and processing sensory information from the body. It basically helps you understand where your limbs are in space.
Okay.
But the insula, which is nestled deep inside the cerebral cortex, is the master GPS. It is the core hub for something called multisensory integration.
Multisensory integration, so taking all the raw data and making it a unified experience.
Exactly. The insula takes everything you see, everything you touch, your sense of balance, your internal organ sensations, and your emotional state, and it stitches all those separate data points together to create the singular, cohesive feeling of you.
Wow.
Yeah, it is the biological reason you know your hand belongs to you without having to constantly look at it to verify.
So if the connection between that spatial processor, the right parietal lobe, and the master GPS, the insula, is dysfunctional.
The brain simply cannot integrate that specific limb into its overarching master map of the body.
It just drops off the map completely.
Exactly. The limb itself works fine. It sends touch and pain signals up the spinal cords.
Yeah.
The person can feel a pinprick on their leg. But when that sensory signal reaches the brain, the insula fails to claim it as part of the self.
It just rejects the data.
Right. The master GPS basically says, I am receiving sensory data from a leg, but according to my core architectural map, we do not have a left leg. Therefore, this leg currently attached to us is a foreign, alien object.
That is deeply unsettling. It's not a psychological delusion where they think the leg is made of wood or glass or something.
No, they know logically that it's a human leg.
Right, their brain just absolutely refuses to grant it citizenship in their body.
Denied citizenship is a great way to describe it. It's a profound neurological rejection. But importantly, the text points out the biology isn't the entire story here.
There's more to it.
Yeah, Dr. Montel highlights a complex psychological layer as well. Early experiences of trauma and the complex process of identity formation during childhood also play a massive role.
Wait, how does the psychological trauma intersect with that neurological broken map? Like, how do those two meet?
Well, think about how a child builds their sense of self. They're observing their environment, their parents, their peers. Now, imagine a child born with this neurobiological vulnerability, this weak connection to the insula, where their leg already feels somewhat alien.
Okay, so the hardware glitch is already there.
Exactly. If that child then experiences a highly stressful environment or early life trauma, their developing psyche is overwhelmed. The brain needs a coping mechanism. It needs a physical scapegoat for all that psychological pain.
Oh, wow. So it latches onto the limb that already feels disconnected?
Precisely. The psychological pain and the neurobiological mismatch fuse together. The brain essentially says all of this anxiety, all of this trauma, all of this distress, it's all because of this alien leg.
So it tells them if I just get rid of this leg, I will be whole and the pain will stop.
Yes. It becomes a perfect, devastating storm of nature and nurture, creating a dysphoria that is incredibly resilient to change.
Which brings us to the really tough part of this. So what does this all mean for the patient? Like, if the brain's mapping is fundamentally broken from birth and then compounded by childhood trauma to form this concrete identity, how do we possibly fix it?
This is where we run straight into what I would call the treatment paradox. And it is a grim reality for patients. Currently, there is no standardized or universally effective therapy that cures body integrity dysphoria.
Wait, seriously, we can map the brain, we can identify the broken insula connection, but we can't actually fix the map.
Not right now, no. Psychotherapy, specifically cognitive behavioral therapy or CBT, is frequently used. But CBT is designed to change thoughts and behaviors. It cannot rapidly rewire a congenital deficit in the insula.
Right, you can't talk a hardware glitch into working properly.
Exactly. So CBT doesn't cure the core desire for the amputation. What it does is help the individual manage the intense distress. It tries to improve their coping strategies so they don't completely isolate themselves.
Just to help them keep functioning in society despite the heavy weight they're carrying.
Yeah, exactly.
The article also mentions pharmacological treatments like antidepressants or antipsychotics. Do those move the needle at all?
They do, but with a major caveat. Patients with BID very often suffer from intense comorbidities, meaning other psychological conditions occurring alongside the BID.
Because living with that level of stress has to cause other issues.
Absolutely. They frequently deal with severe anxiety, major depression, or obsessive-compulsive disorder as a result of living with this constant dysphoria. The medications can be highly effective at treating the secondary depression or, turning down the volume on the OCD anxiety.
But they don't resolve the core urge to be disabled.
Right. You might successfully treat a patient to the point where they are no longer clinically depressed, but they will still fundamentally calmly feel that their leg needs to be removed.
Which naturally leads to the most terrifying part of this entire deep dive. Because if therapy only manages the symptoms and drugs only treat the side effects and the dysphoria remains hard to bear, human beings get desperate.
They really do.
The article highlights the extreme lengths this pain drives people to. They seek out underground surgical amputations, often traveling abroad to unregulated, highly dangerous clinics.
That's incredibly risky.
Or, in the absolute worst-case scenarios, they attempt DIY amputations.
It speaks volumes about the absolute severity of their psychological pain. They're willing to risk bleeding to death or suffering a massive fatal infection just to align their physical body with their brain's internal map.
They'd rather risk death than live with the leg.
Yeah, the physical danger of a DIY amputation is less terrifying to them than living another day with the alien limb.
So ethically, this puts the medical community in an impossible position. Based on everything in the text, if the suffering is that intense and the psychiatric treatments are so ineffective and patients are actively resorting to highly dangerous, life-threatening self-amputations.
Yes, I know where you're going with this.
Wouldn't a safe, sterile, clinical amputation performed by a board-certified surgeon technically be considered harm reduction? Isn't surgically losing a leg better than a patient losing their life in a desperate DIY accident?
You've just articulated the absolute epicenter of the surgeon's dilemma.
Mm-hmm.
From a pure, pragmatic harm reduction standpoint, you can absolutely construct a logical argument for that.
Right, because the goal is to keep the patient alive.
Exactly. If the goal is to keep the patient alive and relieve suffering, a safe surgery seems like a solution. But the profound ethical and medical considerations prevent this from being legally or morally viable right now.
Because it fundamentally violates the core tenet of medicine. Right. First, do no harm.
Exactly. Surgeons are bound by the Hippocratic Oath. If you look at the entire history of medicine, surgery is designed to do one of two things: remove diseased, necrotic tissue to save a life, or repair broken tissue to restore physical function.
And this does neither.
Right. Amputating a perfectly healthy, functioning limb with healthy blood flow, healthy muscles, and healthy nerves, it goes entirely against the core tenets of medical ethics.
Even if the quote-unquote disease causing the life-threatening distress is located in the brain's mapping of that limb.
That is the exact debate happening in medical ethics right now. But legally and ethically, the vast majority of medical boards consider the removal of healthy tissue to be a mutilation, regardless of the patient's psychiatric distress.
It's just a line they won't cross.
And furthermore, what happens if the surgeon complies, amputates the left leg, and the patient's brain map simply shifts?
Oh, wow. What if the dysphoria moves to the right leg?
Exactly. The stakes of an amputation are permanent. If a surgeon performs the operation, are they actively treating the patient's holistic well-being, or are they irreparably enabling a psychiatric condition? There is no clear consensus.
It's just an impossible bind. The patient is suffering immensely and just wants the pain to stop. The surgeon desperately wants to relieve that suffering, but cannot inflict permanent physical damage to healthy tissue to achieve it.
Which is exactly why Dr. Montel's article insists that body integrity dysphoria cannot possibly be handled by a single doctor or a single specialty. It requires highly integrated, multidisciplinary care.
Right. You can't just have a surgeon and a patient making this decision in a vacuum.
Exactly. You need mental health professionals to manage the acute psychological distress and trauma. You need neurologists to continue studying and understanding the brain mapping deficits. And crucially, you need medical ethicists involved to help navigate this impossible moral landscape.
It takes a village, basically.
It really does. It requires comprehensive, ongoing assessment and support because there are simply no easy answers.
So what does this mean for the rest of us? I mean, we take our bodies for granted. We wake up, stretch our arms and legs, and just assume that everything is exactly as it should be.
We do.
Through Dr. Montel's research, we've seen that body integrity dysphoria is far from just some bizarre medical oddity to read about. It is a devastating, exhausting reality for the people who live with it.
It truly is.
It's a profound collision of neurobiology, childhood psychology, and incredibly complex medical ethics. It demands our empathy, and it highlights a desperate need for deeper neurological research so we can find real structural solutions for people whose internal maps have fundamentally failed them.
This raises an important question, though, and it's something I want to leave everyone chewing on.
Okay.
We spent all this time analyzing people whose brain maps are fundamentally misaligned with their physical bodies due to, a microscopic congenital glitch in their neural wiring.
Right.
But consider the broader implications of that neurobiology. If our very sense of self, our deepest, most unquestionable feeling of physical wholeness and identity, can be so completely, utterly derailed by a tiny misconnection between the right parietal lobe and the insula,
Oh, man.
how much of our everyday, perfectly normal reality is just a fragile illusion?
That is wild to think about.
We walk around every single day feeling so absolutely certain of who we are, where our edges are, and what constitutes us. But that certainty isn't some objective, universal truth.
It's just a story the brain is telling itself.
Exactly. It is a highly curated narrative constructed in real time by our brain's internal wiring. If you tweak just one tiny wire in the editor's room, the entire fabric of your reality crumbles.
You think you are the one driving the car, but you are really just at the absolute mercy of the machinery inside your head.
Completely.
It definitely makes you appreciate those moments when the map actually matches the reality. Next time you look down at your own hands or stretch your legs in the morning, take a second to marvel at the invisible, highly complex neurological miracle that simply allows you to feel like yourself. Until next time, keep questioning the map.